Welcome to the deep dive. Wow, you guys sent in a ton of stuff about classifying mental disorders.
Yeah, a lot to unpack.
Looks like someone's ready to go deep on this one.
Yeah.
So we're going to take a journey through the history of how we've tried to categorize these conditions.
Okay.
All the way from ancient times to the present day.
Sounds good.
And we'll definitely be unpacking the DSM, the ICD, and the DSM-IV-TR.
The DSM-IV-TR, yeah, it seems to be a big focus for you guys.
Yeah, for sure.
It's a fascinating area.
So, before we get into all the specifics, can we take a step back?
Sure.
Just to talk about the big picture for a sec.
Okay.
How do we even approach classifying something as complex as a mental disorder? Like, what are the different ways of looking at it?
Yeah, you're right. It's definitely not a one-size-fits-all kind of thing.
Right.
There are actually three main approaches to classifying psychological disorders.
Okay.
Categorical, dimensional, and prototypical.
Okay, those are the big three.
Yeah, and each one comes with its own strengths and limitations.
Interesting.
Yeah.
So the categorical approach, I'm guessing that's the one we're most familiar with, right?
Yeah, probably.
It's like saying you have this disorder or you don't.
Exactly. It's very black and white. And that's what the DSM mainly uses.
DSM, that's the Diagnostic and Statistical Manual of Mental Disorders, right?
That's the one.
Okay.
And it basically gives you this list of criteria.
A checklist.
Yeah, like a checklist.
Okay.
And if you meet enough of those criteria, well, you get the diagnosis.
So it's very much yes or no.
Yep.
But I'm sensing there's a but coming.
Well, yeah.
What are the downsides to this approach?
I mean, think about it. Mental health. It's not always that clear cut, is it?
No, not really.
Human experience exists on a spectrum, right?
Yeah, for sure.
And the dimensional approach recognizes that.
Okay.
Instead of just saying yes or no to a disorder, it looks at things more like a scale.
Interesting. So more like, okay, your anxiety levels are at a 7 out of 10 today.
Precisely. It acknowledges that these experiences can, they can be fluid and they can vary in intensity. And then we have the prototypical approach.
Now, that's the one I'm having a bit more trouble with.
Okay, so think of it like this.
Okay.
Imagine the DSM gives you a prototype, a textbook picture of, let's say, generalized anxiety disorder.
Okay.
Right.
Got it.
So the prototypical approach basically says, okay, here's the classic presentation.
Okay.
But we know there can be variations.
Yeah.
Not everyone's going to fit perfectly into this mold.
So there's some wiggle room.
Exactly.
It acknowledges that real people are messy.
Yeah.
And don't always fit neatly into boxes.
Exactly.
I like that.
Yeah.
Seems more, I don't know. Human-centered.
Yeah.
So you mentioned that the categorical approach is kind of the main one, the dominant one.
It is, yeah.
And yeah, that's definitely the one I'm most familiar with.
Yeah.
But where did this whole idea of classifying mental disorders even begin?
Well, I mean...
Did ancient civilizations even try to do this?
Oh, they did, yeah.
Really?
It's fascinating to look back and see how, humans have tried to make sense of mental and emotional suffering throughout history.
Makes sense.
Yeah, I mean, even in ancient Greece, they had concepts like melancholia.
Melancholia, that's like what we would call depression today, right?
Yeah, you could say that.
Okay.
And then, Hippocrates, the father of medicine.
Oh, yeah. What about him?
He had some theories about this, too.
Right.
Yeah, something about temperaments.
Okay.
He came up with this theory of the 4 temperaments.
The 4 temperaments.
Sanguine, choleric, melancholic, and phlegmatic.
Wow, those are some words.
I know, right?
I'm going to have to look those up.
Uh-huh.
So he believed that these temperaments were based on different bodily fluids and that they influenced a person's personality.
Yeah, and could even make them more likely to have certain mental illnesses.
So even back then, they were already trying to find explanations.
They were.
It's like the age-old question.
Yeah.
Nature versus nurture.
Exactly.
Or in this case, is it biology or something else?
Yeah, that's a great way to put it.
Okay, so they're searching for these answers.
Yeah.
And this search continued, I'm guessing.
Oh, it did through the centuries.
Okay.
In the 18th century, we have Philippe Pinel,
Oh.
a really key figure in the development of psychiatry.
Gotcha.
And he kind of shifted the focus to the nervous system.
So more of a biological understanding.
Yeah, you could say that he was convinced that mental disorders actually stemmed from issues in the nervous system.
Interesting.
Yeah.
But I'm guessing we're still a ways off from the detailed systems that we have today, like the DSM.
Yeah, we are.
Yeah.
But Pinel's work, it was an important step.
It was a stepping stone.
Yeah, a stepping stone.
Okay.
Then in the late 19th and early 20th centuries, we have Emil Kraepelin. Yeah, he really revolutionized the field.
What did he do?
He meticulously observed and documented the clinical features of different disorders.
So like taking notes and really paying attention to the details.
Yeah, exactly.
Ah.
He was looking at their cause, how they progress, their outcomes.
So like a detective of mental illness.
That's a great way to put it.
Okay.
And one of his biggest contributions was distinguishing between conditions like manic depressive psychosis, which we now call bipolar disorder, and dementia precox, later known as schizophrenia.
Gotcha. So he was really starting to draw those lines.
Yeah, clearer boundaries showing that they had different patterns and trajectories.
So this focus on observation and recognizing distinct features.
It laid the groundwork for the systems we use today.
Okay, so this is where it gets really interesting for me.
Okay.
Let's talk about those systems.
Okay.
The ICD and the DSM. From what I've read, the ICD came first, right?
You're right.
Okay.
The International Statistical Classification of Diseases.
ICD.
Yep.
The ICD
has a long history.
Going all the way back to 1893.
Wow, that's older than I thought.
Yeah.
But I'm guessing it didn't start out with a big focus on mental health?
Okay. It wasn't until 1949 with ICD-6 that we see a separate section just for mental disorders.
Okay, so that was a big deal.
It was a major turning point.
Like saying, hey, mental health is important enough to have its own category.
Exactly.
Finally, we have a place at the table.
Haha, yeah.
Okay, so the ICD keeps evolving.
It does.
Becoming more comprehensive and detailed.
Yep.
Okay.
And here's a little fun fact.
Okay.
In the late 1970s, the World Health Organization.
They're the ones who manage the ICD, right?
That's right.
Okay.
They teamed up with the U.S. Alcohol, Drug Abuse, and Mental Health Administration.
Wow, that's a mouthful.
It is. We'll just call it EDMHA.
Okay, EDMHA. To try and bridge different psychiatric traditions and come up with a more globally unified approach.
So a true international collaboration.
Yeah.
Trying to find common ground.
Exactly.
That's incredible.
It was.
It makes you realize how much work goes into creating these systems.
Oh, yeah, a ton of work.
So this collaboration.
It shaped the development of ICD-10.
ICD-10, okay.
Which was published in 1992.
1992, got it.
Yep.
So while all this is happening with the ICD, what's going on in the U.S.?
Right.
That's where the DSM comes in, right?
Yeah, it was like a parallel track running alongside the development of the ICD.
So the American Psychiatric Association, they realized they needed their own system.
It did.
Tailored to American psychiatry.
Yeah, like a homegrown system.
Okay, but what were the main reasons for creating the DSM? Was it just wanting something uniquely American?
I mean, that was part of it.
Okay.
But there were other factors, too.
Like what?
Well, one big one was the need for statistical data.
On mental disorders in the U.S.
Exactly. Yeah. They needed a system to help them track prevalence.
Okay.
Identify trends, get a clearer picture of what was happening with mental health across the country.
Yeah, data is power, right?
It is.
Especially when you're trying to understand a problem and figure out how to allocate resources.
Exactly.
Okay, so data was a big motivator.
It was. And then there was the issue of reliability.
Okay.
Remember how we talked about the challenges of the categorical approach?
Yeah, the whole black and white thing.
Yeah, well, in the early days of psychiatry, diagnoses based on psychodynamic theories, they could be pretty subjective. Two clinicians could see the same patient and come up with totally different interpretations.
Oh, wow.
Yeah, so the DSM was partly an attempt to create more consistency, more agreement among clinicians.
Makes sense. So tell me about the early editions of the DSM.
Oh.
Where did it all begin?
Well, DSM came out in 1952, and it was heavily influenced by psychoanalysis.
Psychoanalysis, that was the dominant school of thought back then, right?
It was.
Okay.
So lots of emphasis on the unconscious mind.
Right.
Childhood experiences, unresolved conflicts.
I can see how that might lead to some fuzzy boundaries.
Yeah, you're telling me. And DSM-II...
That came out when?
1968.
Okay.
It followed a similar path.
Still rooted in psychodynamic theory.
Yeah.
But I'm guessing there was a growing sense that these early editions were a bit too vague.
They were.
Not specific enough.
Exactly.
Clinicians needed clearer criteria to make reliable diagnoses.
They did.
So the stage was set for a big change.
It was.
A shakeup.
Yeah, a big one.
And that shakeup came in 1980.
With DSM-III.
DSM-III. This is a big deal, right?
Huge.
Okay, tell me everything.
So DSM-IV marked a radical shift.
Okay.
Away from that psychodynamic focus.
Okay, less about the unconscious mind.
Yeah.
More about what?
It embraced a more descriptive, symptom-based approach.
So less interpreting hidden meanings.
Right.
More about what you could actually observe.
Exactly.
Okay, so it's all about outlining specific criteria for each disorder.
Yep, think checklists.
Checklists, okay.
If a patient met enough of the criteria,
boom, they got the diagnosis.
That's it.
This made it much easier for clinicians to be on the same page.
Much easier.
So it sounds like DSM-3 was all about bringing more scientific rigor to the field.
Yeah, you could say that.
And there was another big innovation with DSM-3.
Oh, yeah.
The multi-axial system.
The 5 axis.
The 5 axis, okay.
This was a pretty big deal.
I remember reading about this.
Yeah.
What was the thinking behind it?
It was all about getting a more holistic view of the person.
Okay.
The idea was that a single diagnosis, like on axis, let's say major depressive disorder, it didn't tell the whole story.
Right, because people are more than just their diagnoses.
Exactly.
So they added axis 3 to look at personality disorders and intellectual disabilities.
Right, because these conditions, they tend to be more long-standing.
Okay.
And they can influence how other mental health issues manifest.
Interesting. So it's about taking a broader perspective.
It is.
Okay, so we've got axis I and axis 2. What's next?
Then you had axis the 3rd, which focused on general medical conditions.
Because physical health problems can play a role in mental health.
Absolutely. It's all connected.
Right. It makes sense.
And then things got really interesting with axis the 5th.
Okay. Tell me more.
This axis looked at psychosocial and environmental problems.
So acknowledging that life stressors can have a big impact on mental well-being.
Exactly.
Things like job loss, relationship problems, trauma.
All of that.
So it's not just what's happening inside someone's head.
No.
It's also about their external world.
Exactly.
It's a much more nuanced approach.
It is.
Okay, so we've got 4 axes down.
And finally, there was axis V.
Axis V, hit me with it.
This was the Global Assessment of Functioning Scale.
GAF scale, I remember that.
Yeah, the GAF.
Okay.
And it was basically a way to assess how well someone was functioning overall.
Okay.
Considering things like work, relationships, self-care.
Got it.
So you see, all these axes, they fit together to create a much richer, more detailed picture of the individual.
It's not just about giving them a label.
Nope.
It's about understanding them in a broader context.
Exactly.
Okay, I like that.
And this multi-axial system, it was a key feature of DSM-3.
Okay.
And it carried over into later editions.
What happened after DSM-3?
Well,
did they just stop there?
No, the evolution continued.
Okay, good.
In 1987, we got DSM-IIR.
Yeah?
Yeah, it was basically a refinement of DSM-3.
Okay.
Clarifying some criteria, reorganizing categories.
Like a tune-up.
Yeah, you could say that.
Then, in 1994, DSM-IV comes along.
Yep.
And it introduces a new concept.
This one was crucial.
Okay.
The concept of clinical significance.
Clinical significance, so that means?
It means that for a diagnosis to be made, the symptoms can't just be present.
Okay.
They have to be causing real problems in the person's life.
So it's not just about checking boxes anymore. Yeah. It's about the real-world impact of those symptoms.
Exactly.
Okay, I'm following you.
And finally, we get to DSM-IV-TR.
The text revision.
Yep, published in 2000.
That's the one that seems to be at the heart of my research.
Oh, okay.
So tell me, what were the major changes with DSM-IV-TR?
Well, it kept the main diagnostic categories from DSM-IV, but they updated the descriptive text and made some minor tweaks to the codes.
To align with the ICD.
Exactly.
And they also expanded on the concept of prototypes, which we talked about earlier.
Yep.
So how did these prototypes work in practice?
Okay, so think of it like this.
Okay.
You have a specific disorder.
Let's say.
Obsessive-compulsive disorder.
Okay, OCD.
So the DSM-IV-TR, it provides a detailed description of what a typical or classic case of OCD might look like.
Okay.
But it acknowledges that not everyone is going to fit that prototype perfectly.
Right. There's room for individual variation.
Exactly.
So it's like having a blueprint.
Yeah.
But you can make some adjustments to fit the specific person.
That's a great analogy.
I'm trying.
Yeah.
It seems like a more flexible and nuanced approach.
It is.
Which I appreciate.
Good.
But I have to ask.
Yeah.
Even with all these revisions and refinements, were there still criticisms of the DSM-IV-TR?
Oh, absolutely.
Right.
No system is perfect.
Right.
And the DSM-IV-TR, it definitely had its share of controversies and debates.
Okay, well, let's dive into those controversies then.
Okay.
Hit me with the critiques.
Okay, so one of the biggest criticisms was the whole question of validity.
Validity, okay.
Some critics argued that the DSM's categories, They didn't really reflect real distinct conditions out there in the world.
So are we kind of imposing these artificial boundaries on the spectrum of human experience?
Yeah, exactly.
Trying to fit square pegs into round holes.
Exactly. And then there was this issue of whether the DSM was pathologizing normal experiences.
Okay.
Taking everyday struggles, anxieties, and turning them into disorders.
Right, because we all feel sad sometimes.
Yes.
We all get anxious.
It's part of being human.
Exactly. So where's the line?
Right. When does it become something that needs a diagnosis and treatment?
That's a tough question.
It is.
Okay, so that was another big critique.
Yeah, and another one was that the DSM focused too much on symptoms.
Okay.
And not enough on the underlying causes.
So instead of asking, why is this person having these symptoms?
Yeah.
We're just putting a label on the symptoms themselves.
Exactly.
Like treating the symptoms without really getting to the root of the problem.
Exactly.
Okay, makes sense.
And of course, there were concerns about cultural bias.
Right. Different cultures might view things differently. What might be considered abnormal in one culture could be totally normal in another.
Absolutely.
And the DSM might not always capture those nuances.
It doesn't.
Okay, so despite its strengths and the progress it represented, the DSM-IV-TR wasn't without its flaws.
It wasn't perfect, no.
But it sounds like these criticisms were important.
They were.
They pushed the field to keep evolving.
Yeah.
To keep searching for better ways to understand mental health.
Exactly. It's an ongoing process.
Right, because we mentioned DSM-5 earlier.
That did.
It was in 2013.
Yep.
And it introduced some pretty big changes.
It did.
Like moving away from that 5-axis system.
Yeah, big changes.
I did read a little bit about DSM-5.
Okay.
It seems like they tried to address some of those criticisms.
They did. They tried to make the criteria more precise.
Okay.
Clarify some categories and consider cultural differences more.
Makes sense. It shows how much this field is constantly evolving.
It does.
Makes you wonder what the future holds for classifying these disorders.
It really does.
It's exciting to think about the possibilities.
It is.
One area I've been reading about is biomarkers.
Oh, yeah. Biomarkers.
They seem promising.
They do.
So remind me, what are biomarkers exactly?
Okay, so imagine these measurable biological indicators that can help us identify and diagnose mental disorders.
So things like brain imaging.
Yeah, brain imaging, genetics.
Okay.
Even blood tests.
Wow, that would be huge.
It'd be a game changer.
So much more objectivity.
Yeah.
Not just relying on what people tell us and what we observe.
Exactly.
We could actually see what's happening biologically.
Exactly. And it could help us understand how these conditions work.
Yeah.
Which could lead to better treatments.
More targeted treatments.
Exactly.
Instead of just treating the symptoms,
yeah,
we could actually address the root causes.
That's the goal.
That's amazing.
It is exciting, but of course, this kind of research, it's still early.
Right.
And there are ethical things to think about.
Of course, we don't want to create more stigma.
Exactly.
Okay, so biomarkers are one thing.
Yeah.
What else is out there on the horizon?
Well, another area that's getting a lot of attention is personalized medicine.
Ah, personalized medicine. I've heard that term.
It's the idea that treatment should be tailored to the individual.
Not just the diagnosis.
Exactly.
That makes sense.
Because what works for one person might not work for another.
Right, even if they have the same diagnosis.
Exactly.
So personalized medicine, it uses information about...
Yeah, like their genetic makeup, your lifestyle.
Their environment.
All of that to create a treatment plan just for them.
That's so cool.
It is.
It's like moving away from that one-size-fits-all approach and embracing the complexity of human experience.
Exactly. It's recognizing that each person's journey with mental health, it's unique.
It is.
And it's about giving people the power to be involved in their own care.
I love that.
Yeah.
So as we wrap up this deep dive, what's the one thing you want our listener to take away from all this?
I think the biggest takeaway is that our understanding of mental health is always evolving.
It's a journey, not a destination.
Exactly.
And the DSM, in all its different versions, it's been a valuable tool. But it's not the be-all and end-all.
It's just one chapter in a much bigger story.
Right. And as we move forward, it's important to stay curious.
Keep learning.
And be open to new ideas.
Absolutely.
Well, we've covered a lot today.
They have.
Explored the world of classifying mental disorders.
From ancient Greece to the DSM.
It's been fascinating.
It has.
Seeing how our understanding has changed over time.
And it's clear that it will keep changing.
Yeah, there's still so much we don't know.
There is.
But the research happening in this field is truly inspiring. We hope this deep dive has given you a good foundation.
Yeah.
And made you want to learn more.
Keep exploring.
Remember, knowledge is power.
It is.
And the more we understand about mental health, the better we can support ourselves and others.
That's so important.
And before we go, just a reminder about these classification systems.
The ICD, the DSM.
They're tools.
They're meant to help us understand,
Yeah.
to navigate the complexity of mental health.
But they don't define us.
They're guidelines, not labels.
Absolutely.
And in the end, what matters most is compassion.
Empathy.
And supporting each other on our mental health journeys.
Couldn't have said it better myself. Thank you so much for being here today.
It's been my pleasure.
And to our listener, keep exploring this topic.
There's a whole world of knowledge out there.
Keep diving deep.
Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with your friends. Your support helps us keep creating valuable content like this. And if you haven't already, hit that subscribe button and ring the notification